And we'll be talking to you about some of our research progress updates on clinical COVID-19 phenotyping updates. So the outline of the talk, we'll be talking about two of our projects. One is a public resource that we're developing that we're calling COD-COVID. The second is a COVID-19 subtype analysis. So the first project is COD-COVID. COD stands for Columbia Open Health Data. And most of this research work was performed by our research staff associate, Jay Lee. So this work is an extension of our resource that we already have publicly available, Columbia Open Health Data. And Columbia Open Health Data is essentially a public research data set that aims to assist researchers with by providing clinical statistics that we've mined from CUIMC's clinical data warehouse. And essentially, the COD data set provides EHR prevalence rates of conditions, drugs, procedures, sex, ethnicity, and race, as well as the co-occurrence counts and the association metrics between any pairs of these concepts. And to provide easy access to these data sets, we have a web interface that users can use to easily extract the information, as well as a RESTful API that people can use to computationally query these data sets. So for example, in the web interface, users can search for pairs of concepts, and don't worry, you don't need to search for these concepts by ID. You can search, you can start typing in names like atrial fibrillation, and it'll autocomplete to search for those concepts for you. And the information that it provides will be giving you for example, the prevalence rates of each of the individual concepts. For example, 2.5% for atrial fibrillation in the EHR prevalence, as well as for heart failure, we're seeing 3% in the clinical data, and the association metrics between these pairs of concepts, showing that these two pairs of concepts are associated with a positive association rate of 2.6, to show that these two concepts clinically occur together more frequently than expected. So to extend on the work from our previous COD data sets, we're trying to provide 3 data sets that are geared towards helping with COVID analysis. And these 3 data sets come from 3 cohorts of COVID-19 patients that have been hospitalized, with data sets coming from December 2019 through June 2020. An influenza hospitalized patient cohort with data coming from September 1st, 2014 through April 2019, as well as just general hospitalized patients, again with data ranges coming from September 2014 through April 2019. And the COVID-19 and influenza cohort definitions were adapted from an Odyssey Network COVID-19 study-a-thon. And essentially, these cohort queries identified hospitalized patients that either have a condition related to SARS-CoV-2 or a positive lab measurement for the virus. Additionally, we stratify each of these cohorts by sex and age. So age, we're looking for adults between 18 and 64, or seniors 65 and over. And for each of these cohorts, as well as each of these strata, we provide the prevalence and co-occurrence rates. And another distinction between the previous COD data set and the current one, we are looking at these prevalence and co-occurrence rates on a per visit basis, as opposed to per patient basis. And the choice for doing this was so that we can have similar time windows of comparison between the 3 data sets, between the COVID patients versus the influenza or general hospitalized patients. And so the data workflow essentially starts from the CUIMC clinical data warehouse, which is transformed into the OMOP common data model. From there, we extract each of these 3 cohorts. And from each one of these cohorts, we analyze the OMOP's standard clinical data tables to extract conditions, drugs, procedures. We exclude any concepts that have a count of 10 or smaller, and this is a protection step to mitigate the risk of patient re-identification for patients with rare conditions. After that, we do the EHR prevalence analysis, which includes calculating the prevalence rates in the EHR, as well as the co-occurrence statistics And here we also perform a Poisson randomization on each of these counts, which slightly perturbs the true counts. And again, this is to mitigate risks of re-identification. Here are the descriptive statistics of each of these three cohorts. For the COVID-19 cohort, we found about 3,200 patients with about 54% male, 45% female, approximately 47% adult, and 50% seniors. And among the 3,200 patients, we had about 3,600 inpatient visits. For the general cohort, we had about 140,000 patients, about 38% male and 61% or 62% female, approximately 65% adults, and 36% senior. And these totaled to 240,000 inpatient visits. For the influenza cohort, we had approximately 2,500 patients with 45% male and 55% female, and 45% adults and 55% seniors, totaling approximately 2,900 inpatient visits. And to just give a kind of example of the information that could be coming from the COD data sets, we looked at the most common conditions and looked at how their prevalence rates across the full cohorts, as well as stratified by sex and age. And the most common conditions that we saw included dyspnea, acute lower respiratory tract infection, disorder of respiratory system, hypoxemia, cough, acute renal failure syndrome, essential hypertension, acute hypoxemic respiratory failure, viral pneumonia, and fever. And we see that the rates between males and females were mostly fairly similar, with males having slightly higher rates of disorder of respiratory system, cough, and especially acute renal failure syndrome, and acute hypoxemic respiratory failure. Looking at the prevalences stratified by age, we see that adults have slightly higher rates of acute lower respiratory tract infection, but seniors have much higher rates of hypoxemia, acute renal failure syndrome, and essential hypertension. Similarly, we took a look at the most common drugs, again, with the prevalence rates from the full cohort, as well as stratified by sex and age. And the most common drug ingredients were acetaminophen, enoxaparin, glucose, hydroxychloroquine, ceftriaxone, sodium chloride, insulin, potassium chloride, heparin, and sanicides. The drug exposure rates were fairly similar across males and females, with slightly higher rates in males for glucose and hydroxychloroquine, ceftriaxone, and insulin, and females had slightly higher rates of potassium chloride. Comparing the adults versus senior populations, the adults had higher exposure rates of enoxaparin, whereas seniors had higher exposure rates of glucose, ceftriaxone, and insulin. For several symptoms that were commonly recognized across literature to be symptoms that were related to COVID-19, we looked at the Odyssey network defines concept sets to identify these symptoms, meaning that these are not a single concept within OMOP, but a network, a defined concept set defined within the Odyssey network, including multiple concepts related to, for example, dyspnea. And we're looking at these rates of symptoms across the three cohorts. We'll compare the COVID-19 cohort versus the influenza cohort, and we do see higher rates within the COVID-19 cohort for dyspnea, cough, and abdominal pain, and fairly similar rates between COVID-19 and influenza cohorts for fever, fatigue, and nausea and vomiting, whereas the influenza cohort had higher rates of diarrhea and myalgia. There are some issues, though, with comparing these prevalence rates between the three cohorts, because most of the data for the COVID cohort comes from after the COIMC transition to EPIC, versus the data for the cohorts for the influenza and the general hospitalized patients came before then. So to do a quick analysis of how the transition to EPIC may have affected our data for the COVID data sets. We looked at a small time window from December to the end of February, and we looked at the daily occurrence rates of individual condition concepts in this time frame, and looked for differences between prior to the switch to EPIC and after the switch to EPIC. And we did see that approximately a fourth of the conditions that we evaluated had significantly different behavior related to the transition to EPIC. So this could affect our comparisons between the COVID cohorts and the baseline cohorts. So to summarize, the development of the COVID data set is ongoing, and once it's prepared, we will be releasing it to covid.cod.io. The COVID data set will provide concept prevalence rates and co-occurrence statistics from the COVID, influenza, and general hospitalized cohorts. And we will need to provide data quality metrics so that users can evaluate the stability of each of these concepts so that they can evaluate the confidence in the results when comparing across cohorts. And for our second project, we have developed a method of developing patient vector embeddings, essentially vector representations of patients. And we want to see how we could leverage this for COVID-19 subtyping. So essentially our patient vector embedding model works by extracting the EHR information from the OMOP structured data. So we extract the conditions, drugs, procedures, and labs for each patient. We sequence all that information temporally so that we essentially have a timeline of clinical concepts for each patient. And then we treat this timeline kind of like a natural language document. And we apply Doc2Vec, which is a machine learning model borrowed from the natural language processing domain, to learn vector representations for patients. So we use both the distributed memory and distributed bag of words models from Doc2Vec, and we trained it using all patients from the CUIMC OMOP database, using their entire patient histories. And each of these models, the distributed memory and distributed bag of word models, had 100 dimensions each, and we concatenated the two vectors to represent each patient. For the COVID-19 patient vector inferencing, again, we use the Odyssey Network Studyathon cohort query to identify the patients, resulting in 3,300 patients. We extracted all conditions, drugs, procedures, and labs starting from December 1st, 2019. And we applied the model that we had trained previously to do patient vector inferencing for each of these patients. And we used TSNE to visualize the vector representations.
You have 2 minutes, Casey.
Yep, I'll try to speed up, thank you. So we have, next we performed k-means clustering to try to identify subtypes within COVID-19. We have tried the elbow method to select a K, which had a relatively broad curve, so we just selected a K of 5. And these are results. So for each of the subtypes, we try to characterize them by looking at the conditions that are prevalent in at least 20% of each of these subtypes. And essentially, the subtypes that we find correlate or kind of correspond with the severity of the disease. So we'll start from the left with the orange subtype. About 25% of patients fall into this subtype with relatively few symptoms. Maybe about 25% of them have dyspnea. The blue and the green subtypes are relatively similar to each other, so I'll describe them together. They have moderate symptoms and conditions, including higher rates of dyspnea, about 45%. They have essential hypertension, cough, disorder of respiratory system, and hypoxemia. The red group have more severe symptoms, and that accounts for about 6% of these patients, with approximately 40% of acute hypoxemic respiratory failure, acute respiratory distress syndrome, acute renal failure syndrome. And the purple group, again, about 6% of the patients have even higher rates, about 50% of acute respiratory distress syndrome, acute renal failure syndrome, acute hypoxemic respiratory failure. And additionally, they have about 30% of sepsis and septic shock. So in summary, The temporal patient vector embedding produced data-driven subtypes that were related to the increasing severity of hospitalized COVID-19 patients. About a fourth of the patients were either asymptomatic or had very mild symptoms, including acute lower respiratory tract infection and dyspnea. About 2/3 of the patients had more moderate symptoms and conditions, including hypertension and hypoxemia and cough. About 12% of the patients had severe conditions, including acute hypoxemic respiratory failure, acute respiratory distress syndrome, and acute renal failure syndrome, shock, and sepsis. Thank you. I'd like to thank our lab members for helping me with this, as well as our collaborators and our funding, and I'll take any questions now.
Thank you, Casey. If you could unshare your slides so that we can get ready for the next speaker. And do we have any questions from the attendees? If so, please go ahead and raise your hands. It looks like Margaret has a question. Margaret, you should be able to talk.
Yes. Hi, Casey. Are you able to share any additional demographic data beyond gender?
So right now we've chosen to stratify by just sex and age, because one of our limitations for providing these data sets publicly is that we tried to limit the number of concepts that are, we can't provide any concepts that have a count of lower than 10. So we don't want to stratify the data sets too much, because the further we stratify the data sets, the fewer counts we'll have for each of the concepts, which limits our ability to share that information.